Let me introduce to you David Pecora. He's been an EMT in rural Pennsylvania since 1979. And he moved to Tampa, Florida in 81, completed a 2-year paramedic program. He was a senior paramedic and field instructor for Hillsborough County EMS in Tampa, as well as a flight paramedic and preceptor for Tampa General's Air Medical Program. He took the 3rd PHTLS class back there when the rest of us were babies, working with PHTLS in 1986 with Dr. McSwain and others. In 2000, he completed a physician assistant program and then a 3-year physician assistant emergency medicine residency at West Virginia University Hospitals. He's a nationally registered paramedic as well as a physician assistant in emergency medicine. He's a friend of MTEP and been a friend of many of us that have been fighting the fight in EMS for quality education and for science. So I'm very pleased and honored that Mr. David Pecora has joined us tonight to talk to us. So David, I'm going to flip it over to you.
Yes, hello there. Good evening. Can you hear me okay, Will?
Yep.
Okay, great. Good evening, everybody. Thank you all for taking the time out to attend these educational events, the McSwain Trauma Project. Attending these events definitely speaks to your commitment to taking care of trauma patients and increasing your knowledge. As most of you are aware, I'm sure trauma is the #4 killer of people in the United States. Dr. Norman McSwain spent his life dedicated to care of these trauma patients by being an excellent surgeon as well as an educator. And I'm sure Dr. McSwain is currently looking down at us tonight with a big smile on his face. So thank you all for attending and doing what you're doing. We all definitely appreciate it. So some of our objectives tonight is to understand the pathophysiology of shock, list some common signs and symptoms of shock that we see, recite the important care of shock in the pre-hospital setting, and know the basically the 3 mechanisms of shock. And so the 3 mechanisms, the first one is the pump. We're dealing with the heart. And to keep things simple, so the pump, the heart, the pipes, the blood vessels, and the fluid, talking about the blood. Oops, I'm sorry there. You know what? I'm trying to advance sorry there, people.
No problem. You're good.
Okay, so yes. And speaking of the fluids there, you see #1 there. It is a big help to have your IV bags numbered, that's for sure. When you go from that pre-hospital setting to the ER to another facility, it's great to know what number IV bags. Is that IV bag #1 or is it #6? But so to continue on here, the 3 components of shock. On the far left-hand side of the screen, you see some simple terms there. The pump, the clinical term is the heart. And then going down to the pipes, which is the vascular tone and vascular resistance. And then the fluid, of course, is the blood volume that we deal with. So let's do the pump first. So the pump body releases catecholamines from the adrenal glands, which are located on top of your kidneys. So clinically, when these adrenal glands secrete the catecholamines, what we're going to see clinically is an increase in our heart rate. So let's see. So cardiac output, stroke volume times heart rate. Okay, so let's take a healthy adult, weighs about 70 kilos. The cardiac output can be calculated by 2 measurements, the stroke volume and the heart rate. A patient's weight in kilograms is approximately their stroke volume in milliliters. So if a 70 kilogram patient, their stroke volume is going to be about 70 milliliters. And the same with an 80 kilo, it's going to be 80 milliliters. Which is the stroke volume, the amount of blood being ejected out of the left ventricle with each contraction, with each heartbeat. In this example, the patient's stroke volume will be 70 milliliters, like I mentioned, and heart rate found in your exam is 70 minutes. So stroke volume, 70 milliliters times your pulse rate, that will equal about 4,900 milliliters, or basically 5 liters. In a 70 kilogram patient, their blood volume is about 5 liters. And now let's take this to clinical use. This patient, this 23-year-old female, falls off the ladder. She falls about 6 feet. She has a bruise to her left flank where the kidney lives. I'm sorry, where the spleen lives. Of course, the kidney is back there also. Her vital signs, you see there, 118/88. Her pulse is 160 a minute. Her respiratory rate is 28. So we can, let's see here. So the patient's bleeding, obviously probably from her spleen and possibly from her kidneys. So the adrenal glands, which are located on top of your kidney, will be releasing epinephrine, which epinephrine's job is to increase the pulse rate. Norepinephrine is also secreted, and norepinephrine is a potent vasoconstrictor. That's why we use norepinephrine like vasodilatory problems such as shock to vasoconstrict the vessels. And we can appreciate this patient's increase in pulse rate simply by taking the patient's pulse or looking at your monitor and seeing exactly what the pulse rate is. The increase in the heart rate is compensatory for a while until it's not. And that's why we're dealing with this thing, the pump. But so let's just go on. Now let's talk about the pipes. Let's see here. So the pipes we're dealing with, these are vasodilatory problems with these types of shock, vasodilatory problems, anaphylactic shock, neurogenic shock, septic shock. These are examples of all forms of shock involving the pipes. Specifically with anaphylactic shock, being a vasodilatory problem, we're going to be using different medications such as epinephrine. Epinephrine has both beta and alpha properties. Beta 1 increases your heart rate. And the way that I remember that is you have one heart, so beta 1 affects the heart. Beta 2 medications that we give, also is contained in epinephrine, are bronchodilators. And how I remember that is you have two lungs. So beta 1 is your heart, beta 2 the lungs, bronchodilatory effects, and alpha very potent vasoconstriction of the blood vessels. So all three of these properties will help the patient anaphylactic shock by simply with just one medicine, epinephrine. It has both beta and alpha properties. Now let's talk about hypovolemia, hemorrhagic shock versus hypovolemic shock. Hypovolemic shock, talking about all the different types of fluid loss, whether that's from vomiting, diarrhea, sweating, etc. So the rest of this talk is pretty much dealing with hemorrhagic shock. Okay, I keep forgetting to advance it. I apologize. So Dr. R. Adams Cowley, some of you probably have heard his name before. He's the founder of the world-renowned Baltimore Shock Trauma Center in Baltimore, Maryland. In 1975, in an article that he wrote, he stated the first hour after injury was largely determined a critical injured person's chance of survival. So the term the golden hour came to being. The golden hour concept and terminology was then born from Dr. Cowley. Dr. Cowley was trying to win support for Shock Trauma Hospital and a statewide helicopter program in Maryland at that time. A companion of the golden hour arose in the pre-hospital setting, and the folklore developed called the Platinum 10 Minutes. These ideas spawned a billion-dollar industry in Maryland, trauma centers, air medical programs. This concept is established by much less rigorous scientific research. That is the golden hour. It's backed by very little, if any, scientific research. The fact of the matter is there is significant positive data to support the golden hour, and there is solid evidence to refute it. The use of red lights and sirens is going through some very serious evaluations also at this current time of the country, as well as what types of patients actually need to be flown, fixed wing or rotor wing, the risk versus the benefit. So 90% of all trauma deaths occur within the first 24 hours, with the majority occurring within the first few hours of injury. Immediate and early deaths account for a majority of the trauma deaths, with less than 10% deaths occurring late in the ICU. Hemorrhage accounts for a significant portion of these deaths at the scene as well as in the hospital. Historically, we have used the term trimodal distribution of trauma deaths, which was originated from Dr. Trunke. And again, like everything else in medicine, nursing, things evolve. What we're doing now is probably going to be outdated in 5 to 10 years, and we'll be looking back on even some of the things I'm saying now, and people are going to be shaking their head. What were they thinking? But anyway, so years ago, the trimodal distribution of trauma deaths was described, and the trimodal distribution of trauma deaths was death immediately at the scene. Reason, if there was a surgeon such as Dr. McSwain at the scene, there was probably no chance of survival. Well, maybe not 100% true, but you get my point. So they die initially at the scene. Number 2 phase is they die at the hospital in the above time frame. And then number 3, they die at the hospital in a longer period of time after admission, and they usually succumb to infection during longer hospital stays. So the trimodal distribution of trauma was first described by Dr. Trunke, and those are the immediate deaths at the scene, and then the early deaths, and then the later deaths, such as in the ICU and in rehabilitation centers. So right now, the trimodal distribution of trauma deaths is come under great scrutiny, and what we're moving towards is this thing called bimodal distribution of trauma deaths. And most significantly, the earlier deaths are occurring much sooner, effectively shifting them closer to the immediate death group. This is partly due to significant increase in gunshot wounds in this country, especially. Some of the improvements in the death rate, though, is an improvement of the pre-hospital care, resulting in early arrival of injured patients to the hospital with such courses such as PHTLS, pre-hospital trauma life support, that Dr. McSwain, as I'm sure many of you are aware, and others developed that course following after the ATLS course. So the new bimodal trauma death distribution, you can see there's pretty much, we're talking about the first 4 hours. We're shifting much of the deaths more towards the left, whereas only about 10% now are actually dying in the ICU. And the decrease in the death rate in the ICU is attributed to good pre-hospital care, as well as the significance that emergency medicine has evolved into in dealing with trauma care patients. Before it was pretty much strictly the trauma surgeon, but now it's more of a team concept where emergency medicine is definitely assisted in the reduction in trauma deaths. So they're all on the same page. Shock is a physiological state characterized by a systemic reduction in tissue perfusion below that is necessary to meet the metabolic needs of the tissues and organs. Hypoperfusion results in oxygen debt occurring as oxygen delivery becomes unable to meet the metabolic requirements. Hypoperfusion is a time-dependent emergency. Even though that the golden hour has pretty much come out of favor, the basic concept, though, still remains. The time is of the essence, and to greatly decrease our on-scene time to only those procedures that are truly necessary to decrease the patient's morbidity and mortality. Okay, we may find a so-called isolated injury, such as an isolated fracture, but these in and of themselves can be life-ending or combined with another injury greatly contribute to their mortality. Femur and pelvic fractures are most often associated with large amount of blood loss. Pelvic fractures can run from stable with minimal blood loss to catastrophic hemorrhage of the entire blood supply. Edema occurs in the injured soft tissue. Tissue injury results in activation of systemic inflammatory response and production of release of multiple cytokines. Cytokines have a profound effect on vascular endothelium, which increases permeability. So not only are they bleeding out into their femur, they're also losing their fluid volume through their cells because of increased permeability. Okay, so hemorrhagic shock, some physiology here. So cardiac output, which is defined as the volume of blood pumped by the heart per minute, it's determined by multiplying the heart rate by the stroke volume. So heart rate times stroke volume, that equals cardiac output. Preload, the volume of venous return to the heart, about 70% of our blood is in the venous system. If we are bleeding, we lose the amount of blood returning to the right side of the heart, which greatly affects the cardiac output. Decrease in blood volume in the right ventricle significantly affects the Frank-Starling effect of the right ventricle. That is, if the right ventricle has significantly decreased volume of blood in it, the less forceful will be the contraction from the right ventricle. The whole principle behind the Frank-Starling effect, the more we stretch those myofibrils, the stronger the force of contractility there will be. But if there's a significant decrease in venous blood returning to the right side of the heart, the Frank Starling effect won't be nearly as strong because there's much less squeeze and much less stretch from the myocytes to force that blood out. Afterload, which is involving the systemic peripheral vascular resistance, that is the resistance of blood being pushed forward. Hemorrhagic shock primarily affects preload. Again, we see a decrease in venous blood returning to the right side of the heart. Maybe it's from a lacerated liver, ruptured spleen, fractured pelvis, and so on. So uncontrolled hemorrhagic shock eventually leads to hypotension due to an acute decrease in cardiac output. The intrinsic response to hemorrhagic shock is stimulation of the sympathetic nervous system via baroreceptors, which result in an increase in heart rate in an attempt to preserve cardiac output. We have baroreceptors, that shows in this diagram here, in the carotid bodies. Those sense a decrease in pressure. We also have chemoreceptors in the carotid bodies, which will monitor changes in the pH or acidity, alkalinity of the blood. In most cases of hemorrhagic shock, when we're dealing with this, talking about the sympathetic nervous system, we're going to see tachycardia. And this is probably one of the earliest measurable signs that the patient is in shock, is an increase in the heart rate because of the release of epinephrine from the adrenal glands. Unfortunately, in elderly patients, specifically with them, they may be on a beta blocker, and they might not be able to mount this tachycardic response because even though epinephrine is being released from their adrenal glands, they're on a beta blocker, so it will block or stop the effects of beta 1 and beta 2. And again, beta 1 involving the heart, an increase in heart rate. So you won't see that reflexive tachycardia in the elderly, which further contributes to their higher mortality rate, depending on their medicines. So sympathetic nervous system stimulation as a result of the response to blood loss are compensatory in nature. They result in progressive vasoconstriction of the cutaneous, muscle, and visceral circulation. What we're trying to do, the body's trying to do, is preserve blood flow to the heart and the brain. This is why with massive vasoconstriction, we see the patient that often has cold and clammy skin in shock. We take their capillary refill, which is going to be greatly prolonged. You also feel their skin, the extremities, and they're going to be very cold from decreased perfusion. What the body is trying to do is shift the blood supply from the skin, the muscles, and the gut towards other organs that need this oxygenated blood on a higher level, and that is, of course, the heart and the brain. So catecholamines, endogenous catecholamines such as epinephrine and norepinephrine are released from the adrenal glands, like I mentioned, and they increase peripheral vascular resistance, which in turn increase the diastolic blood pressure. We also have the renin-angiotensin axis. Renin is released from the part of the kidney. When there's a decreased blood flow to the kidney senses this and then releases this renin-angiotensin axis is activated. The renal medulla releases aldosterone, one of the most potent vasoconstrictors in the body, as well as increasing reabsorption of sodium and water. We also have osmoreceptors in the hypothalamus that release antidiuretic hormone, ADH, which causes reabsorption of water. ADH's job is to retain fluid. We see this clinically by decreased urinary output. That is why a Foley catheter is inserted, which is a great way to tell how the patient is being perfused. You may be asked to transport a trauma patient with a Foley in place, and this is why. So it's a great way to tell how the patient is being perfused. So antidiuretic hormone, again, exactly that, antidiuretic hormone, it keeps the fluid in. When we drink alcohol, beer, wine, whatever, it prevents the release of antidiuretic hormone. That's why when we consume alcohol, beer, etc., we urinate a lot, is because antidiuretic hormone is not functioning, and we get very dehydrated. So let's see here. So the sympathetic nervous system, it does result in an increase in blood flow to the heart and the brain due to this significant vasoconstriction and an increase in heart rate. Everything is geared towards saving the the brain, and of course the heart also. Let me see here. Sorry, I'm trying to do, let's see here. All right, so some clinical signs that we are going to see is going to be a change in the patient's mentation. This is because of decreased perfusion to the brain. And also the patient is losing their oxygen carrying capability, their hemoglobin, maybe bleeding out into their belly from a lacerated liver, ruptured spleen, or they may be losing it out on the highway through an open fractured femur. So they're losing their oxygen carrying capability, the vehicles that transport this oxygen. If you take oxygen or glucose away from the brain, the patient is going to experience an altered mental status immediately. What else we're going to see because of this release of epinephrine from the adrenal glands is tachycardia. Let's see here. And because of the norepinephrine that we spoke about, you're going to see a cool, clammy skin from potent vasoconstriction, as well as a prolonged capillary refill. And also a narrow pulse pressure. The diastolic pressure will actually rise due to this potent vasoconstriction. And as mentioned, with the release of ADH, antidiuretic hormone, you'll see a decreased urinary output. So it's good if you're doing critical care transports and you're taking a patient from a small, maybe a critical access hospital to a level 1 or level 2, and they do have a Foley catheter in place, is to find out what their urinary output has been while that patient is in the ER, and then for you also to monitor it while you're doing your transport. One of the things I did when I flew at Tampa General, one of our criteria, one of our mandates was to empty the Foley when we arrived at the patient's bedside, and that way we could monitor the patient's urinary output during our transport times, which could sometimes be up to an hour and a half in different parts of Florida at that time. So a rough estimate as far as the systolic blood pressure is simply feeling the pulse location. If you have a radial pulse, the systolic blood pressure is approximately 80, as you see here. If you have the carotid pulse, of course, 60. And if there's no pulse, obviously, you're going to be starting CPR if there's no carotid pulse, or that may be an indication of termination of death and ceasing all resuscitative efforts. If the femoral pulse is present, the systolic blood pressure is probably around 70. And like everything else in medicine and nursing, these are all just, not engraved in stone. These are just rough guesstimates, basically. All right, so skin perfusion changes in hemorrhagic shock. In this picture here, you can, I'm not sure if you can see it very well, but you'll note some modeling of the legs of this little guy in this picture here because of potent vasoconstriction. Skin perfusion and its changes are early indicators of shock, especially in the pediatric patient. It starts distally, of course, and then ascends towards the trunk as the shock worsens. Okay, let me see here. I'm trying to do two. Okay, so systolic blood pressure, as I'm sure most of you are aware, a drop in that is a very late sign of shock. Significant hypoperfusion occurs in blood-penetrating trauma despite normal standard vital signs. So the patient could still have normal, pretty much within normal limit vital signs, but still be bleeding out somewhere in their body unrecognized, or initially possibly unrecognized, especially when you're dealing with a young, healthy patient. They can maintain for long periods of time until they don't. One of the strongest scenarios that comes to mind when I was flying at Tampa General, we were requested to fly to Rollerson Memorial Hospital, which is on the east coast of Florida. At that time, when I was flying with Tampa, of course, that's on the west coast. The call came in about 1 a.m, and this has been on the news and things like that, so I can use the patient's name. And this was around 1990. But Matthew Simmons was a 9-year-old boy who was out camping with his parents. They took along their neighborhood friend, and Matthew and his buddy were playing around. Matthew being 9, they were playing around with a BB gun, and Matthew sustained a BB gun penetrating injury to right underneath his right clavicle. So the family put him in the car and drove him to the local hospital, a non-trauma center. and he was hemodynamically perfectly stable. And Rollerson Memorial is a community hospital in Florida. I believe it's still this way. It's mandated by state law that any penetrating injury to head, neck, chest, or abdomen has to go to a level 1 or a level 2. So Rollerson Memorial, being on the East Coast, they called their local trauma centers, Miami, other places. They were all filled up. They could not take Matthew. So then they finally made their way down, and then they called us. I was working with a brand new flight nurse, Heather, and she was extremely excited. She just got released from her probationary period, and she heard about this, a gunshot wound, as she called it, under the right clavicle, and she ran and got the 4 units of O negative blood that we could bring with us if we felt necessary. And I just wasn't impressed with this kid's story at all. He was hemodynamically stable. He'd been in this ER now for 8 hours. But she wanted to bring the blood, so of course we got the blood and we brought it. And our flight time was there. It was about 50 minutes or so. And as we landed, we went into the ER, and I was pulling the stretcher, and Heather was at the head. And as the curtain was pulled back, I looked at Matthew. He's sitting up in bed, and he was very pale, extremely pale. He had little beads of sweat on his forehead as he was coloring in this book. Mom and Dad were at the bedside. And nurse report, of course, was given, but he had been there already for like 8 or 9 hours. So there'd been a significant change in shifts and in staffing. So he really was kind of just put in the back and said, yeah, the helicopter's come in to get Matthew, and he's been just fine. And then over here in this bed, we had this other person. So it's not, I'm not trying to put blame on the hospital, but he just kind of was set to the side. And then we got there, we put it, the minute Heather and I realized how pale he was, looking at the monitor, his heart rate was like in the 130s. We very quickly had Mom and Dad say goodbye to him. Mom wanted to come, but we could not do that because we realized that Matthew wasn't doing too well. So we had Mom and Dad kiss him goodbye, put him in the helicopter. We advised our pilot to do go ahead and start the helicopter. We went out there and flew him to, on our way to Tampa General, we were over Lake Okeechobee, which if you look at the maps, of the largest lake in Florida. I was seated at the head of Matthew. Heather was at his side, and I'm looking at Matthew, and I could see the monitor there hanging on the wall, and I see his heart rate slowly accelerating, 130, 135, 140, 145, 150. And even though he was pale before, I even can see more significant paleness develop. His lips were already pale, but they even became more pale, and his diaphoresis increased. So his heart rate accelerated to about 180, and then in reverse, slowly started bradying down. He went unconscious, unresponsive. We started CPR. We weren't really supposed to tell our pilot, the condition of the patient, but he can hear the activity going on. And in now it's called an EC 145 or a BK 117 at that time. There's a wall separates the patient compartment from the pilot. But we did tell our pilot, and my exact words to him was to pedal fast. So we're on our way to back to Tampa General, and intubated him. He was a little bit difficult to ventilate. No lung sounds on the right, but as you all know, generally when you intubate, you end up being a right mainstem intubation. But his no lung sounds on the right was definitely not due to the intubation, but because of his penetrating injury to the right anterior chest wall there with his BB. So we ended up putting in bilateral chest tubes on the right side. We did get out at least about 500 cc's of blood, and then we clamped off that tube. The blood that I didn't think we need, well, we started hanging the O negative blood that, thank God, Heather, that we brought. And when we arrived at Tampa General, he's taken to the pediatric ER. They cracked his chest. Stuart Ford was the chief trauma resident, and the attending was there. And a large amount of blood just poured out of his right side of his chest. And to make a long story short, he ended up being resuscitated as far as his heart, but he ended up dying 2 days later. In an autopsy, what happened was a right BB was found in his right subclavian vein, not the artery, but the vein. And as you all know, venous bleeding is slow. And possibly one of the speculations is maybe when we put him in the aircraft with the vibrations of the EC-145, maybe it dislodged the BB. We weren't sure, it's hard to tell. But anyway, he had a significant, that BB did strike his right subclavian vein, and he bled out pretty much into his right anterior, into his chest cavity there. But when we look back on that case, as far as relating to this and blood pressure being a late sign, where we looked at his vital signs from arrival till the time we got there, you could slowly see this increase in the pulse rate from the nurse's documentation. You also could see a slow increase in his respiratory rate, in just a really a small incremental change drop in his blood pressure. and a rise a little bit of his diastolic pressure. And as you all know, the little ones, the little fellas and the younger people can compensate for so long until they don't, and then their vital signs and everything else just drops like a rock. And that case will always stick in my mind there, significant blood loss. But again, the systolic blood pressure, a very late sign that we shouldn't rely on. So in adults, tissue hyperperfusion is apparently starting with a systolic blood pressure greater than 110 now. Before we used to say 90 and below, but now with the new systolic blood pressure guidelines, we really should be looking at 110 to increase our awareness that maybe shock is occurring here. We definitely shouldn't feel comfortable to let our guard down just because the patient's systolic blood pressure is between 90 and 110. Hypertension has gone way up in this country. Patients' BP may normally be 140 over 88, 150 over 90 or so, especially if they have untreated hypertension. Hypertension still remains in this country the silent killer, and if it goes untreated, it could definitely, of course, cause strokes. But no longer should we be relying on the blood pressure of 90 to 100 to indicate to us the patient is in severe shock. We should increase that number now to at least, like it shows in this diagram here, up to about 110. Patients older than 70 years also have a much higher mortality after trauma compared with similar younger patients with the same type of trauma. Elderly patients have lower cardiac output. They're pumped. Their myocardium doesn't work as effectively as a younger person. They have a significantly decreased ability to compensate when they're under hemodynamic stress. And they definitely have a significant interrupted response to increased sympathetic tone. Elderly patients also have multiple comorbidities, maybe multiple MIs, maybe some strokes in the past, all of which can contribute to their mortality, and especially like we mentioned, if they're already on beta blockers, we're not going to see that tachycardic response. Okay, so since we can't really rely on the blood pressure, then what should we rely on? So a neural pulse pressure, which is looking at the systolic and the diastolic and subtracting those two, with compensated shock, we're going to see an increase in that diastolic pressure. And this is probably going to maintain the systolic blood pressure, but pretty much what we want to concentrate on is that diastolic pressure increasing a little bit. And that again is from the catecholamine release, especially the norepinephrine, which is a potent vasoconstrictor. All right. And then also, how about shock index? So shock index is heart rate divided by the systolic blood pressure. It's a ratio of heart rate in beats per minute divided by the systolic blood pressure. And it's commonly used to assess the amount of blood loss and the degree of shock the patient is currently going through. The normal shock index should be about 0.5 to 0.7. A shock index greater than 0.9 indicates significant blood loss. Again, in geriatrics, you may have to be cautious with using the shock index because of their medicines they're on, or they already might have a significantly elevated systolic blood pressure due to untreated hypertension. So here's an example here. So the normal patient's heart rate in this example, say a 70, systolic blood pressure is 120. So you divide 120 into 70, you get 0.6. Actually, it's 0.58. But remember, the normal is 0.5 to 0.7. So this patient's shock index is within the normal range. Now let's take a trauma patient. The heart rate increases to 160 a minute. The systolic blood pressure is down to 80. You divide the 80 into 160, you get a shock index of 2. And again, anything basically above 0.9 is a serious indicator of shock. So it is very useful to use whether you're in the pre-hospital setting or even in the hospital setting, the shock index. And it's good to document that also. So we have shock index, and then we also can talk about urinary output. Sorry there.
Sorry, my fault.
Glucosuria, urinary output can be affected by glucosuria, such as you all know, diabetic ketoacidosis patients. They're polyuria, polydipsy, that type of thing. So they can pour out a lot of urine. Patients ingesting a lot of alcohol, as we mentioned, because it stops to prevent release of antidiuretic hormone. They urinate out a lot, especially and also with diuretics. So keeping an eye on that urinary output is very useful indicator of how well the patient is perfusing. The more blood loss they have, the more antidiuretic hormone is going to be excreted. So their urinary output is going to significantly decrease. And you see the values there on your slide. The adult should be about 0.5 milliliters per kilo an hour. And these are just the very, very minimal numbers. And then the infant all the way down, shows there is 2. So the younger the patient is, a little bit more urinary output you should expect with them. And if you're starting to see a decrease in that urinary output, that's a good indicator that the patient is in significant shock rather than just simply having to wait for the blood pressure to drop. And also in the pre-hospital setting now has become the use of ultrasounds. It's being used more and more in the pre-hospital setting, especially in helicopters and in fixed wing programs. In northern Minnesota, where I'm at, there's 3 helicopters in the surrounding area, and all 3 of those programs utilize ultrasounds. And there's one ground EMS system in the area that also uses ultrasound. And so we can use the ultrasound in the pre-hospital setting to look at ventricular function. How good is that squeeze there? We can use it to assess volume status. You can use it to look at the inferior vena cava and see if it's plump or whether it's really flat. You also can use it to assess the lungs. Does the patient have a pneumothorax? You can also use it to not only for the pulmonary status, but since you're right there taking a look at the heart, maybe the patient has cardiac tamponade. You also can use it to check the abdomen very quickly. Is there fluid in the belly? Now, a lot of these things that we're talking about, whether it's starting an IV or using the ultrasound, definitely should not prevent us from starting to transport to the hospital. A lot of these things are nice, and are fancy in the pre-hospital setting, but they definitely should not deter us from getting the patient to the hospital. And one of the sayings that I've heard Dr. McSwain say, basically the patient needs a surgeon with a scalpel, not a paramedic with a catheter. And then it's been out there for many, many, many years now, but I clearly remember him saying that. And that should be our goal, is to get the patient to definitive care rather than staying in the field and doing all these different things. But they do help, though, as long as you're en route to the hospital, especially here in rural Minnesota, where we do have long transport times. So let's see here, just to go on here, doing interfacility transfers, for those of you involved with that, it's important, if you can, to ask about the lactate level if the facility has that. Lactate or lactic acid reflects an imbalance between glycolysis and glucose oxidation. This acid is made up in muscle cells and red blood cells. It forms when your body breaks down carbohydrates for energy. Muscle cells and red blood cells make the most lactic acid in your body. When your body starts producing energy anaerobically or with little oxygen, then the lactic acid is created. Elevated levels are of concern, but the time to clearance of lactate back to normal levels is most predictive outcome in hemorrhagic shock. Lactate levels greater than 1 indicates some serious shock. Be aware that as under perfused tissue, beds become reperfused. The accumulated lactate that's been sitting there may now get washed out into the periphery, causing a temporary elevation and a false reading of the serum lactate levels. Ability to clear lactate to normal is very important in predicting the significance of the trauma, as well as the mortality. So hemorrhagic shock in the treatment priorities. Like with every patient that we deal with, whether you're in the pre-hospital setting or in the hospital, airway breathing should take priority immediately. If you're dealing with airway and breathing issues, you want to take a look for and have a suspicion for tension pneumothorax, both by the mechanism of injury, maybe by the use of the ultrasound, and of course the stethoscope, which is sometimes, as you all know, difficult to utilize in the field, in the back of an ambulance or in a helicopter. But tension pneumothorax significantly decreases venous return of the superior and inferior vena cava, so they become extremely hypotensive. Tension pneumo is more of a breathing problem than it is a fluid problem. I'm sorry, just the opposite of what I said. It's more of a volume deficit problem. It's decreasing return to the right side of the heart. The tension pneumo is compressing against the superior and inferior vena cava, decreasing that venous return. People live all the time just with one lung. So if a patient does have a tension pneumo, their other lung, they can still exchange oxygen just as well. So when you're dealing with these patients initially, is there shock from a tension pneumo? Again, listen to lung sounds, mechanism of injury. If you have an ultrasound, utilizing that. Is there hypotension from cardiac tamponade? Again, mechanism of injury. The use of ultrasound is very helpful with that also. Let's see. So if the patient is bleeding out, they're going to be losing their oxygen carrying vehicles, their hemoglobin, whether into their belly or out into the highway. So the body, since they're losing their hemoglobin, their oxygen carrying capability, the body changes from aerobic metabolism to anaerobic metabolism. The patient is also losing their platelets, which assist in clotting of the blood there. So as far as the Trendelenburg, different positions we can put the patient in, the Trendelenburg position was originally used to improve surgical exposure of the pelvic organs by this German surgeon Trendelenburg. After World War I, its use of this Trendelenburg position became very common practice in treating shock patients, but there is definitely no solid research to support its use. So it's not that it's discouraged, but it's no longer recommended for use like in the PHTLS manual or even the current edition of the ATLS manual, the Trendelenburg position. So mechanical means of stopping some hemorrhage, we can utilize pelvic binders. As we mentioned before, you can definitely lose a significant amount of blood through a fractured pelvis alone. So we have applied these pelvic binders to decrease the size of the pelvis and to close that gap, basically. We're trying to create a tamponade effect. Tourniquets have been extensively studied in multiple wars, period. And the use of tourniquets has greatly improved outcomes in taking care of patients, especially nowadays. We have all these explosions, that type of thing, IADs and on and on. They are definitely a safe and effective, but a lot of the current research is showing also that they're being put on needlessly. That is, maybe the patient has a laceration that may be bleeding profusely, but basic maneuvers should be attempted first. Direct pressure, elevation, use of pressure points like the femoral artery, that type of thing, before we immediately jump into the use of a tourniquet. Because with use of the tourniquet, we are going to be significantly decreasing or stopping that arterial blood flow, which is going to cause tissue necrosis, and the patient may lose their extremity. And of course, we all realize that, you know, we're attempting to save the patient's life over their extremity. But just give a conscious thought before you put on a tourniquet. Does this patient really need this tourniquet? And is there other ways that I can initially attempt to stop this bleeding before putting on the tourniquet? So another mechanical means of stopping hemorrhage that's really come about is the different hemostatic dressings. They're made of different things, but the ones that are available currently on the market are either gauze that's impregnated with clotting factors. There's also sponge, there's gel, there's powder, and there's granular forms of this. And they work by delivering and concentrating procoagulation factors at the bleeding site. So they accelerate the formation of clots at the local site of the bleeding. And these have been shown to be very effective, especially in wartime use. Unfortunately, every time that there is a war World War I, World War II, the Korean War, Vietnam War. One benefit of those wars, I hate using that word benefit, but is trauma care greatly improves every time there's a conflict. And this is one of the ways that TXA has come about, as well as these hemostatic dressings, is from wartime use, military use, which then comes down to civilian use. So IV access and concerning shock, as you all, I'm sure, well aware, large bore, short length is what we're after. Large bore, the bore of the diameter of the catheter is much more important than is the length. You can infuse a much larger volume of fluid through a 14 gauge than you can a 22 gauge. But having said that, though, you have to realize that generally the crystalloids we're giving in the pre-hospital setting, one, are probably going to be cold. Patient's normal temperature is 98.6. A crystalloid bag, maybe in the back of an ambulance, I'll even pick 70 degrees. So 98 minus 70, that's a considerable difference. So you're administering a large amount of cold fluid to that patient. Trauma patients don't like to be cold. And the crystalloids, ringers, or saline do not carry oxygen. They pretty much fill an empty space. We use crystalloids in attempts to move what hemoglobin they do have left to the vital organs that need this oxygenated blood. When we are trying to start IVs, it should be done en route, as most of you, I'm sure, are aware, unless the patient is trapped. If you can, luckily in Tampa, we were lucky enough to have 2 paramedics on each ambulance, or even EMTs nowadays, of course, thankfully, can start IVs. So having 2 people in the back of the ambulance when you're en route to the hospital, attempting to start IVs. 2 or 3 IVs is preferable. If you cannot get an IV, then we, of course, as you all know, we have interosseous available also. And concerning the IO site, for the adult-sized patient, the proximal humerus site is definitely much preferred over the tibial site. Generally, the tibial site is reserved for pediatrics. The humeral site is much larger. You can insert a larger amount of fluid through the humeral site than you can the tibial site. All the different IO needles are all the same diameter. They're all 15 gauge diameter. The only thing that changes is the length. So the yellow hub one is 45 millimeters in length, and then of course the red one is even shorter. There's a nice app from EasyIO that's downloadable, and it's free and has some great videos, training videos on the use of their product. By no means am I an IO representative, but I just know what's out there and just wanted to pass that on to you. So there's 3 different IO products out there approved by the FDA. One is the FAST. One is, it's called the big injection gun, and then the EasyIO that probably most of us are familiar with. If you have the IO needle in place in the humeral site, you can infuse rates up to 150 milliliters a minute, can be achieved if you use a pressure bag. When you do insert an IO needle, you just simply can't have the IV bag or blood products hanging by force of gravity and expect to be able to infuse in a large amount of fluid. You're either going to have to use a pressure bag or have somebody squeeze that bag, or even use the manual blood pressure cuffs, even if those are even still around anymore, to squeeze around that blood product through an IO line, because it's not going to flow in as simple as it would as if it was a 14 gauge IV catheter. So some of the things you want to avoid is if you have a fracture at that site, if there's significant infection. All this is risk versus benefit. One of the problems with using the IO line is if there's extravagation of that fluid into the extremity, the patient can develop compartment syndrome, and the patient has enough to deal with now without having to deal with the compartment syndrome. So pre-hospital placement of IVs, the Eastern Association of Surgery for Trauma in the 2009 guidelines, and this still exists today, is there's no evidence to support IV placement at the scene. En route is certainly okay, but not like we used to do years ago, starting the IV, and we always would pride ourselves. How many IVs did you get? Oh, I put in 4, 16 gauge in that patient. You look at our scene time, we were there for 45 minutes. And as you all have heard this before, all bleeding will stop eventually. We can still start the IV, even if you're not going to be infusing fluid, simply just using a saline lock. If you are going to administer fluid, it's recommended now, instead of like 1 to 2 liters wide open, using small increments of fluid boluses, preferably warm fluid, and looking at their pulse rate. more than trying to get that systolic blood pressure up. We're pretty much should be looking at the a little bit of a decrease in the pulse rate. And remember, again, the crystalloids in the field are cold, and trauma patients definitely do not like to be cold. Okay, all right.
We have some questions when you're ready for them, Dave.
Sure, yep, I know we got 3 minutes there. So too much fluid, too little fluid. Ongoing shock, continued acidosis, coagulopathy, myocardial dysfunction, all these will result if you have too little fluid. If you give too much fluid to the patient, it's a dilutional problem. They can develop compartment syndrome. It's just like the Goldilocks principle, too much or too little. We should take into account. And there's a debate out there in the pre-hospital setting, even in the hospital, normal saline versus ringers. Pretty much the debate comes down to ringers is preferred now over normal saline. Large amounts of saline can go to hyperchloremic acidosis, but ATLS now and PHTLS now recommends lactated ringers over saline. Okay, I'm just gonna, let's see here. So with the crystalloids, again, they don't carry oxygen. So if it doesn't carry oxygen in it won't clot. So like it says there, don't give it to me. As far as the blood products, packed red blood cells, that does carry oxygen, but no clotting factors. Plasma does contain the coagulation factors, and platelets help with adhesion and clot formation. So you may be doing critical care transports where you're asked to carry some of these blood products. But again, packed red blood cells is probably what the patient needs, is it'll increase their oxygen carrying capability. So medications here, is there a role for those? TXA is being well studied, and there is good solid research that shows that TXA probably should be given sooner rather than later. It should be used in the first 3 hours, though, if it's going to be used at all. And this slide here, the triad of death, we're dealing with acidosis, coagulopathy, and hypothermia. It's a continuous cycle there, so keeping the patient warm and trying to prevent acidosis by administration of oxygen and fluids, preferably blood products. So let's see, I know we got about a minute here at the most left. I'm just gonna get to, let's see here. So restricting our fluid administration, we don't want to pop off those clots that the body has taken such great diligence in making and developing. And again, those pre-hospital fluids are probably going to be cold, leading to hypothermia. ATLS and PHTLS initially advised, a high concentration of administering fluids, chasing that tachycardia. But currently what we're dealing with is damage-controlled resuscitation, getting the patient to definitive care, where emergency medicine and surgery as a team effort can deal with the fluid loss by administering blood products and restricting the fluid just to give permissive hypotension, not trying to bring up that systolic blood pressure anymore, and damage control surgery. TEG is another product that has just come about lately, and that is, you'll draw a TEG sample, and that will evaluate exactly what the patient needs. Do they need platelets? Do they need hemoglobin? That type of thing. So TEG is really on the forefront now and used by major trauma centers in this country, and it's being studied extensively. So you'll hear more about that in the future, TEG. So let's see here. I'm sure I know we're getting close to the end there. So this is my hero there. This is the last time that I'd seen Dr. McSwain at the EMS World Expo conference. Will, I believe, was here also, the World Trauma Symposium. And these are some different quotes that Dr. McSwain has made over the years. And one of his most popular one was the last one there. What have you done for the good of mankind lately? Which I always remember him saying. So I appreciate everybody's attention tonight. And I'm not sure how much time we have, Will or Mary, but.
Well, we can take some questions, David. Thanks. First one was, can you talk about the utility of using MAP rather than just systolic blood pressure?
Yeah, so the mean arterial pressure definitely is a much more valuable vital sign to look at than just simply the systolic blood pressure. As the patient's going to be, the mean arterial pressure, as the patient is bleeding out, the body is going to attempt to maintain MAP at all costs. So measuring the MAP or calculating the MAP is much more useful vital sign to monitor, and you would need to trend that like all of our vital signs, but it's definitely come to the forefront in trauma, and it's much more of an important vital sign or a number to keep track of rather than simply the systolic blood pressure.
Another question for thanks, Dave. Another one would be, sorry, I lost the list here. How about on humeral IOs? A couple of questions. One, what do you think EMT should be allowed to do them down the line? And also, is there a guideline for humeral head IOs and peds?
Well, it depends on what state you're in as far as certification licensure. Here in Minnesota, EMTs are allowed to place IOs. EMTs in this state are allowed to place IVs. So an IO is just an extension of that. So you would just have to follow your local and your state protocols with that. But currently the humeral site is only recommended for adult-sized patients. It's currently not recommended for pediatrics at this time, just adult-sized patients.
Yeah. Seeing if we missed one here. All right, you mentioned lights and sirens. I'm actually, my literature review this month that I'm doing that will be published in next month is on a study that's been done with those. And it looks like the emphasis going towards, first of all, looking at the data. This particular one I'm looking at went backwards and looked at the patients over a period of time and see if there was a critical indicator as far as people who had critical interventions that would have to be given within a certain amount of time that would justify getting there quicker than you might have in other cases. And then using that to set like a dispatch standard. Have you seen anything, adding to that discussion?
The majority of things that I've seen is not using red lights and siren to the hospital anymore, and except under extreme circumstances, which would have to be dictated by the medical director. But risk versus benefits, I forgot the numbers. The Department of Transportation keeps track of this, but how many lives are lost or maimed, healthcare providers or innocent bystanders by an ambulance running emergency to the hospital, and just the risk versus benefit type thing. But what's coming about on the forefront is the patient would have to meet a certain criteria before red lights and sirens are used, and it's very few patients that really deserve the use of red lights and siren. Again, just the risk versus benefit thing.
Yeah, like 3 points to what you're getting at is one, first of all, the data, which is like there's a 50% increase in the opportunity for ambulance crashes if you're doing lights and sirens, and that only 7% of the patients, really needed that kind of immediate attention. So I think, to your point, lights and sirens to the hospital, probably not necessary in many situations, but under dispatch criteria specifically set to immediate need, we may be able to manage the problem a little better and allow some flexibility. So that seems to be what people are looking at. It'll be a while before the data comes through that it's effective, but
yeah, I think it's going to take a while to trickle down. That's for sure. Those types of things are engraved in, just hard to change behaviors.
Yep. I thought you brought up a lot of good points in your talk. I think the idea that a lot of, particularly those of us that have been around for a long time, you mentioned taking pride and you got the IV done on the scene. And I even had some medical directors even recently said, I don't want you, doing this stuff, get in the ambulance. It's like the changes protocol. Don't call me if you're still in the house. Do what you got to do and get them out of there. I think we're seeing some more emphasis on that stuff, that it's important to get them where they got to be first when we're messing around with stuff. And even the data on more invasive procedures, to your point, isn't that good if it increases delay? They can be useful and necessary for patients, but if it increases the amount of time it takes to get a critical patient to surgery, that benefit starts to be erased.
Yeah, definitely. Yeah.
Well, we're going to about 9:07. I don't see a lot of questions still coming in. Let me do a quick read. Well, I want to thank you, David, for joining us tonight. And I know the crowd appreciates the amount of time you put into this. So I want to thank you for joining us.
Yeah, definitely. I should have kept it shorter. I definitely went over.
Sometimes requires that you go over, and we're flexible. Again, I want to thank everybody for joining us tonight. We're not here if you're not listening. Remember what we're doing, what the McSwain Trauma Education Project is all about. And if we basically also don't exist unless we get input from you as far as what your needs are. We don't want to be presumptuous and say, this is what you need to hear. Tell us what you need to hear. What can we talk about that helps you do your job? Give us places where we can travel to. And if you want, or you've got a good place you think would be good for the McSwain Trauma Education Project to come to, we'd love to come to you and run a one-day conference with you and bring speakers to you, and also partner with your local speakers to get a good thing going together. Remember that we are a nonprofit, that whether it's $1 or 100, or whatever you can do, if you like what we're doing and you want to contribute to Dr. McSwain's mission, go online, give us what you can, tell us what you need, and we'll try to get it done. I don't think you're going to find a place that's more immediately responsive to what people tell us they want to hear about or they want to do. We'll get on the case.